Okay, Brother Leroy, we are ready. Go.
And this is the Wisdom Table. We're thankful to the Most High for blessing us with the opportunity to be with you and you to be with us. It's a great day when we can communicate with one another, share information, knowledge, wisdom, and hopefully get some understanding. The Wisdom Table, I'm the co-host, Brother Leroy, along with our engineer today, and the chat room is available as we get into this program. The Wisdom Table does not reflect the views, attitudes, whims, deeds, or any other proclivities of the resident association of Grand Houses, nor does what we say and explain on this program reflect any of the attitudes or opinions of the management of this NYCHA development. However, the program does reflect the research done by the participants in the program live and live in color and by Zoom. And of course, there is you by way of chat. And our guest today is Dr. VELBA Bowles of Louisiana by way of North Carolina. Our subject in part is the ventilator, the use of ventilators in the COVID-19 situation, I'll put it that way, and alternatives. We'll get into that. Also, very important, we will deal with the immune system, building the immune system, protecting the immune system, which you do not hear this kind of information over the general media. And that's why independent media is so very valuable to you and I. Dr. VELBA Bowles, thank you for joining us on the Wisdom Table.
Well, good afternoon, everyone. I always enjoy being a guest, and I thank you for thinking of me as someone who can impart information to the community. So I am very, very honored to be invited.
Okay, and we're going to, well, you got it from here, Doc.
All right. Well, what I understand that we want to cover today, partially what I'm sharing is a video that was released by a emergency medicine doctor in New York. Now, this video is about 2 weeks old, but when I first saw it, it triggered a lot of interest in me because I have worked as an emergency medicine physician. I did that for 18 years in Louisiana, Missouri, and South Carolina. And when I heard the emergency medicine doctor telling his observations, it triggered my memory of how important it is not to just have academic people defining situations. We really need to hear what is being observed by those who do this every day. And in hearing this doctor, which we will play a 6-minute or so clip, maybe 5 minutes of the 6-minute clip, where you can hear what he said also. But before we get into that, I wanted to review why it struck me that what he was saying is so important. First, my comment is because the nation is now finally acknowledging that people of color in America are among the group that is most susceptible to an adverse, meaning death. I'm gonna be very frank, not just an adverse outcome, but most susceptible to the possibility of death from the viral infection of COVID-19. We need to be very candid and direct to the audience who should have their ears peaked as to what are the treatments for this disease, what are the preventions, and so forth. This emergency medicine frontline doctor made an observation that at least up to 2 weeks ago, the method that we were all talking about, it was not enough ventilators, not enough ventilators. And they were talking about turning the industries from car industries into ventilation productions to vacuum cleaning company making ventilators. So someone paused and said to me, Dr. Bowles, what exactly is a ventilator? And I said, you know what? We use language and don't explain it. So I'm going to start there, Brother Leroy and audience, and I hope that it will be helpful. When we talk about a ventilator, we're talking about inserting into the trachea. That's why you usually see this tube going through the mouth. It goes in the mouth and into the trachea, which we know as the windpipe. And we put it into a position such that a machine, which is very much like a pump, it is in fact a pump, can push oxygen and it can push other things. In anesthesiology, we may be pushing whatever it is to help you go to sleep. But in the case of ICU treatment, we are pushing oxygen into the lungs, and we're pushing it directly. We're not allowing it to go through the nose. We're not allowing it to go through the mouth. We are putting it into the windpipe and pushing it into the lungs. In situations where the person has pneumonia, or the person has been near drowning, or any condition where the lungs is filling with water or mucus, this pressurized oxygen is life-saving, because you're pushing the fluid out and replacing it with oxygen, which we need to survive. What you will hear when we play the video, this frontline emergency medicine doctor said what he was observing was not pneumonia. In other words, what he saw was the persons who were very ill with the COVID-19 infection did not have a fluid accumulation in the lungs. Consequently, when we were just knee-jerk putting the ventilator on and putting in the trachea and giving the PEEP, as we call it, which is pressurized oxygen, we could very well be doing harm. He went on further to identify what he thought he saw rather than pneumonia is a condition we physicians know as ARDS, which is acute respiratory distress syndrome. ARDS is a totally different mechanism than pneumonia. And the way in which you save someone's life who has ARDS is very different from what you do when the person has pneumonia. Now, we have other ways, something called ECMO, which is an extracorporeal oxygenation machine, which we have used in a crisis situation. Sometimes we may even give steroids to slow down the process, but there are mechanisms other than ventilation. And the caution that this young doctor was giving is if we, without pausing to evaluate this process, but there's just knee-jerk, go and put them on a ventilator, we can, in some instances, hasten or speed up the death of someone who's already very sick. And my concern is we know the target victim. It says senior citizens, and we all say, oh my goodness, senior citizen. We hear all these numbers from these senior citizen homes, and then they whispered, and people with comorbidities. Well, I'm here to tell you, comorbidities identify possibly 70 to 80% of Black Americans. Now, someone said, that sounds like a real big statement. It is, because in these United States, our healthcare is driven by insurance companies and income. If you do not have a high rate insurance company, or you cannot pay out of pocket, you will not get the best healthcare in America. You will get less efficient medicine. Why do I say that? Because insurance companies will dictate what they will pay for. So your best doctors can write the best prescription using their best intelligence and training and not be able to give you what you need, because an insurance company will say, we do not pay for that on this insurance plan. If your patient wants it, they must pay out of pocket. And often it is some ungodly amount of money to the tune of $400 to $600 a month for some of these newer pharmaceutical treatments. Consequently, the population, brown people, Black people in America, are getting 30-year-old medications. They're getting generic medications. So their treatment of diabetes and their treatment of high blood pressure is not the standard of care. What does that mean? It means that the risk for stroke is higher. The risk for kidney failure is higher. The risk for dialysis is higher. The risk for amputations of limb is higher. And no one wants to address that. This is the big secret. This is what no one talks about. Yay for America. We're the industrialized country. We're very rich. But in the medical field, you get only the care your insurance company allows. You get only the care that the federal government formulary list allows. So you are not getting the most advanced care if you're a person of color and you are dependent on a low rate insurance or some government funded healthcare. So with that said, now they're acknowledging that the same group that is getting less standard of care healthcare are most susceptible to the infection of COVID-19. And you say, well, why are they more susceptible? Who drives the city buses? They can't do that from home. Who drives garbage trucks? Who cleans up in the hospitals, janitorial services? The persons most at risk are also most exposed. So if you combine high risk, high exposure, then you start to say, well, okay, they got a comorbidity. They're high risk because of that. They're in a frontline job. You drive a bus, you got all these different people coming in and passing you or touching something that you're near. You're cleaning up in a hospital because you're in the environmental services. Sometimes you don't have PPE, you may have gloves, but no one's giving you a face mask. So it is a setup for the group that you see highest death. In Louisiana, we have 73% Blacks dying from COVID-19, and that to me is an atrocity. So if we are not treating it in a proper paradigm, meaning it's not pneumonia, but ARDS, and the person's most at risk, this is really like a genocide when it comes to Black population in America. So with all of that, if there's no questions or comments, I would ask us to go to the video.
Okay, go straight ahead, sis.
Now, I don't hear anything. Am I supposed to be talking?
No, he's getting up the, he's working to get up the sound on it. The video is showing.
Okay, well, while he's doing that, I want it to be clear that I have not heard anyone come out, anyone in authority, like on the White House staff, and make a comment about what this young man is reporting. However, if you have noticed, there's no real requirement, a call out for ventilators anymore. Suddenly, they're no longer talking about how many ventilators is needed and how many ventilators are being sent here and there. So my impression is someone other than the person that you will hear if we get the sound up has come to the agreement that the process is something other than pneumonia.
I did hear President Trump, or I did see President Trump make a statement from the podium of, you know how many people, I'm paraphrasing, you know how many people survived the ventilator. He said, you know that, don't you? He was talking, well, as he talks, you know, he just turned away from the mic and it was you know what the real deal is, kind of.
COVID-19 lung disease, as far as I can see, is not a pneumonia and should not be treated as one. Rather, it appears as if some kind of viral induced disease, most resembling high altitude sickness. It is as if tens of thousands of my fellow New Yorkers are on a plane at 30,000 feet and the cabin pressure is slowly being let out. These patients are slowly being starved of oxygen. I have seen patients dependent on oxygen take off their oxygen and quickly progress through a state of anxiety and emotional distress and eventually get blue in the face. And while they look like patients absolutely on the brink of death, they do not look like patients dying of pneumonia. I have never been a mountain climber, and I do not know the conditions at base camp below the highest peaks in the world. But I suspect that the patients I'm seeing in front of me look most like as if a person was dropped off on the top of Mount Everest without time to acclimate. I don't know the final answer of this disease, but I'm quite sure that a ventilator is not it. That is not to say that we don't need ventilators. We absolutely need them. They are the only way at this time that we're able to give a little more oxygen to patients who need it. But when we treat people with ARDS, we typically use ventilators to treat what's called respiratory failure. That is, we use the ventilator to do the work that the patient's muscles can no longer do because they're too tired to do it. These patients' muscles work fine. I fear that if we're using a false paradigm to treat a new disease, that the method that we program the ventilator, one based on a notion of respiratory failure as opposed to oxygen failure, that this method, and there are a great many number of methods we can use with the ventilator, but this method being widely adopted at this very moment in every hospital in the country, which aims to increase pressure on the lungs in order to open them up, is actually doing more harm than good. And that the pressure we are providing to lungs, we may be providing to lungs that cannot stand it, that cannot take it, and that the ARDS that we are seeing, that the whole world is seeing, may be nothing more than lung injury caused by the ventilator. Now, I don't know the final answer to this disease. I do sense that we will have to use ventilators. We will have to use a great many number of ventilators, and we need a great many number of ventilators, but I sense that we can use them in a much safer way. In a much safer method. That safer method challenges long-held dogmatic beliefs within the medical community and among lung specialists, which will not be easy to overcome. But I really believe that they must be overcome. There are hundreds of thousands of lungs in this country at risk, and the time to overcome them is now. I'm confident that if those of us that work bedside with these patients, those of us who are witnessing the things that we have never seen before, despite the many years we have worked and the thousands of patients and diseases we have seen, if we can effectively communicate this to all those that are so important but who are not bedside, the researchers, the administrators, those who procure our resources and make our protocols, the politicians, our own governments, if we are able to convince them that this is a disease that is different than anything we have ever seen, I am confident that an answer can be found, that effective treatments can be discovered, and that a plan to disseminate that treatment can be rapidly deployed, and that tens of thousands and probably hundreds of thousands of lives and lungs will be protected. The time for this is now. We are staring into a future in which a great many of our fellow Americans are going to suffer, not to mention people all around the world. For those who will not suffer directly from this disease, from the terrible human cost of this disease, for those who will not lose a family member or a friend, and there will be a great many number of people who will lose those close to them. But for those who don't, they are still going to suffer from the great economic cost of COVID-19. We are all involved in this future. So I urge you, for those of us, if you are out there, for those who work bedside, I urge you to speak up. We can change this. I thank you all for listening. Please spread the message and stay safe.
Okay, that's why when I heard that, it really made me say, okay, this is someone who is seeing a lot of pneumonias, who has seen conditions which are not pneumonias. So it appears now that this is probably the video is about 10 days old, maybe a little older, that the paradigm, now the word paradigm means what is the strategy for treatment. And anyone who has done management or worked into an assembly line, you never get a good success unless you start from the right strategy. You have to know what comes first, what comes second. And as you see more, or if you're an experienced laborer, as you do more, your process becomes smoother and your success becomes better and the job is more professional. So with the concept that the COVID-19 creates a ARDS-like syndrome, then the treatment will change. No longer will they be so quick to put them on a ventilator. They will do some alternative method. Some have asked me about hydrochloroquine, which is a lupus treatment. It's also a malaria treatment. And there was a study, a very small study done that gave a suggestion that it might be useful. And what I caution people who get excited on these little news break information, we are in a certain situation where Hail Marys are okay. Now, anyone who's played sports, I use this analogy. If you're down a point and you have a chance to win and you have a good player and you allow that player to make an unbelievable shot, something that you would never sanction under regular operation conditions, then you understand Hail Marys. We're doing everything. We're looking at malaria drugs. We're looking at anti-Ebola drugs. We're looking at HIV drugs. We're looking at every possible combination. And what we need to tell the audience is that doesn't mean you run out and buy hydrochloroquine. It doesn't mean you run out and start buying anti-Ebola medicines. It says we're in a Hail Mary position. We are trying everything. And we're hoping that we hit upon something which really does work. The most promising right now is anti-Ebola drug medicine. Does that mean that's what we should all go and do? No. The side effects, if you've ever listened to a commercial, when they're talking about a pharmaceutical, they'll say, you know, this will help your depression. Then their second voice will come on and say, side effects include. And when they start listing the side effects, I hope you are hearing that sometimes the side effect sounds worse than the very disease the medicine is intended to treat. Well, that is the precaution when we say, no, we're not telling you that this is a choice. We're trying to let you know that there are some side effects. And in some cases, the side effect can induce conditions into a compromised patient that are equal or worse than the very thing you're trying to treat. So I caution you from listening to these immediate surges of someone was saying you can't take ibuprofen or Motrin, or you're not supposed to take all of this information. If you're listening to it, my caution is it's too soon. If anyone is saying this with definitive knowledge, they are a con artist. There is no definitive knowledge. I can give you experience. We can listen to videos like we just did and listen to someone on a front line. But to date, we have no effective medication against COVID-19. Now, with that, the question I think Brother Leroy and I have discussed on various occasions, what can we do? So I will step back and talk to my Black community because that's where I am most aware of. I worked in the arena with very low income persons, not necessarily of color, but they suffer the same healthcare disparities, meaning you have diabetes that is not optimally treated. What does that mean, Dr. Bose? Your glucose is often above 200 if you do a blood check. Your HbA1c is above 7 if you remember such numbers. You have high cholesterol, so you're on these anti-cholesterol meds. You have high blood pressure, so you're on some kind of ACE inhibitor. Anyone that fits in that category, you are who they are talking about when they say comorbidities. You are the ones that if you contract COVID-19, you are not likely to survive. That is the group that they're talking about. Therefore, you should be asking to get a COVID-19 test. In fact, you should be demanding it so that you have advanced knowledge and you can take care of yourself before you have to go to the ICU, before it's so critical that it's life or death. So the shout out or the new initiatives, at least here in Louisiana, the governor has appropriated and Congress has also appropriated funding for testing in high risk neighborhoods. So senior citizens are not the only specialized group. If you have a comorbidity, you do not have to have the fever of 100.4. And in Alexandria, they recently changed it. Our Region 6 director says anyone in the high risk group can get tested. Therefore, you need to be demanding your testing. You need to know your status. You need to be seeking help very early, not waiting until you're rushed to the ICU and possibly having to go on a ventilator. What can you do to protect yourself? Number one, in the Black community, many of us will have a deficiency in vitamin D. You can supplement vitamin D with vitamin D3. The number 3 is important. If you're taking vitamin D3, you are boosting a part of your immunity that may right now be weak. You should also be looking at vitamin C. Now, please don't go buy orange juice because that's mostly juice with water and sugar. If you're going to get vitamin C, eat your oranges, eat your grapefruits, your lemons. Go back to Mother Nature, eat the natural. Don't go for what is in a bottle that costs $2 to $3 and it's mostly sugar water. If you're going to buy vitamin C, buy a reasonable vitamin C. Don't buy some cheap, chewy candy and say, oh, it tastes good, that's why I bought it. Get serious about this. And the mineral that can help you is also zinc, Z-I-N-C. You don't hear much about zinc, but we know that zinc can be a healing mineral. It certainly can help respiratory conditions, whether viral or bacterial. If you want a natural food, oysters is the food with very high zinc levels. Any kind of nuts, particularly Brazil nuts, are high in zinc. You can buy the zinc lozenges and you can suck on them just like you can the cough lozenges. But you want to do things that strengthen your immune system. The concept of wearing a mask, although somehow there seems to be resistance, the mask is to prevent you from getting infected as much as preventing others from being infected. So if you say, I'm not wearing a mask because I'm not scared, well, fine. But you need to think that if I am the cause of one person getting sick and dying, are you willing to think that I am the reason someone died today? If that's okay with you and you feel defiant, then I feel sorry for you, but you need to be able to think it's not all about you. So I hope that that has addressed the issues. To summarize the video, there are now a new process or paradigm by which they are treating severely infected persons. And notice I said severely. If it's low symptoms where you have a cough, you have a mild fever, then we do what we always do. Like when you have the flu or a cold, you'll get a Tylenol or some other antipyretic. If you have joint pain, we'll give you some pain meds. And I'm sure they use different kinds of cough suppressants. The time that it's a problem for the individual with the infection is when the lungs stop receiving adequate oxygen and cannot supply the rest of the body with needed oxygen. So I hope that that addressed the issues. If there's any questions, I'm good for it now. Brother Leroy? No questions, no comments?
Dr. Bowles.
Yes, sir.
Okay, Brother Leroy went up for a second. I got a question. Because this morning, they had a guy on that runs a black guy who runs 10 or 11 hospitals here in New York. And he mentioned that they were part of a double-blind study to test some promising a particular drug. And he talked about what they did and how they gave them the medicine and nobody knew what was the medicine, what was the placebo. And I'm just wondering, can you talk a little bit about that? So when people hear that there's some type of medicine or something's coming up, the extent that's being used in order to decide whether it's effective or not.
Double-blind studies are considered the gold standard. What that means.
He used that term, by the way.
The pharmacist, well, I used to work double-blind. See, I've been in this business since 1989.
Wow.
When I worked for CDC, we often looked at different drugs at different diseases. And what a double-blind study is, a medicine is brought in and it's labeled A and B, or it can be 1 and 2. And only the persons who are conducting the study back in the lab know what A is and know what B is. And they tell the doctors, treat this medicine exactly the same. A and B are the same. Give patients who have this condition just like you would under any ordinary circumstance. And what that means is they have a very clear way of getting data. That only thing is different is the medicine A or medicine B. So if you have a patient who is have a high fever, a bad cough, muscle aches, and you give them medicine A, and the next patient has a high fever, a cough, muscle aches, you give him B, and then you watch. And every so often, it can be every 3 days, every 5 days, sometimes longer, they look to see, did the symptoms get better or worse? Did the patient feel better or worse? And a better measure is if there were any kind of respiratory difficulty, did it resolve? And when you've done this, let's say 1,000 times, and medicine A has consistently improved the condition of your patient, now you can say medicine A is more effective working than medicine B. And that gives clear data. It's not based on my being prejudiced. It's not based on my liking the company that made the medicine. It's based solely on how the patient responded. And double blind means neither the doctor nor the patient knows which is which. Because you can have a single blind where the doctor knows, but the patient doesn't. So double blind is considered the gold standard because the doctor can't show any kind of bias because he doesn't know what's what. And the patient can't show any bias because they don't know whether they're getting a sugar pill or the real medicine. So double blind is a gold standard, and it allows researchers to now make predictions based on the observed data. So it's the best possible human trial method to get information on possible medication.
Okay, Brother Leroy.
Yes, Doc, in terms of the immune system, before we deal with that in more detail, I want to go back to the R's. And what is it, put us into the hospital situation where they're thinking that it's pneumonia. What are they seeing on the screen and what is the end result of a wrong diagnosis on what they see on the screen?
Well, now that they have another possible strategy, I'm sure they will get more radiologists involved. When you do a chest X-ray or a CT scan of a person in respiratory distress, radiologists and internists and others who are in the front line, ER docs, we start to learn patterns. If we see a certain kind of pattern, we can say that looks like lupus. Or we see a certain kind of pattern, we'll say that looks like pneumonia. And based on the observed and preliminary diagnosis can affect how I treat that person. I may decide to put a CPAP, which is a facial oxygenation device, on someone instead of a ventilator. I might decide to start a steroid like Solumedrol, an IV steroid, instead of trying to go after an antiviral or an antibiotic. So what my preliminary diagnosis is can determine what first line treatment, and the first line treatment often can determine survivability. If my preliminary diagnosis is wrong and I start down, as my mother would say, start down the wrong road, then the outcome will be less favorable because I've lost time. I've been doing something that's not effective, and it's going to show up by you being in a worse condition when I finally say, gee whiz, you know, this isn't working. I need to try something else. So the sooner the preliminary diagnosis is correct, more efficiently can the patient be treated. So with this ER doc's observation and warning, if nothing else, he has raised the consciousness of these other physicians to say, wait a minute, this person got too sick too fast. It doesn't look like typical pneumonia. Let's go consider something else now. So what his warning, hopefully, has started more ER doctors and possibly more pulmonologists to consider alternative treatment earlier. So that's what the bonus is by sharing information such as this when we're in such a high pace. You know, you're talking 700 people died, 800 people died, 600 people died. This is just death everywhere. And the ability for some people to think clearly under pressure is just not possible. You become a robot. You're doing what you're doing and you're doing what you can do best. But if you can have someone who can analyze and step back and say, hold up, we're not an assembly line. Let's start looking at this from a human approach. And that's why I applaud the ER doc who put that video out, that under this intense scrutiny, under this most exhausting circumstance, he's not allowing it to become routine robotic. He is still analyzing. He is still evaluating. And thank him very much for notifying the rest of us that if you haven't considered it, why not? So I think that is very important that we know what we're doing, know why we're doing what we're doing. In other words, don't just put somebody on a ventilator. Why are you putting them on the ventilator? And you notice he spent time talking about the difference between oxygen hunger and pneumonia. See, oxygen hunger, if you think about an asthmatic, and I don't know if you've ever seen anyone with severe asthma, there's a look in that person's eye because an asthmatic can't pull air in. They keep trying, but the bronchial is starting to cramp, if you want to call it cramp, but it's clamping down. Their eyes are open wide, their mouth is open wide, and there's a feeling. You can see if you walk in and you're an experienced emergency medicine doctor, you can say, well, that person's in acute distress asthma. No one had to tell you. You can see the look in the eye. You can see the positioning, their head. They put it in what we call the tilt position. So if you can still analyze and make these kinds of evaluations while on the run, kudos, you're an very exceptional physician. And when you're willing to take the time when you're exhausted to share it, even greater compliment. So I think it's very important that we consider alternative theories in these early stages and not presume that we're doing the right thing.
Dr. Bowles, this is the producer again. I got one other question. So this doesn't mean that whatever they're calling this, it doesn't mean that it's not as deadly as before. It just means that, does this mean that there are another way to maybe treat and relieve the issue?
That's exactly right. That his comment is more addressing treatment than process. He's not saying what the virus is doing, if it's killing lung tissue, if it's closing blood vessels. He's not trying to tell you that. What he's telling you is, let's not knee jerk and say, okay, ventilator, because knee jerk may result in us doing more harm than good.
So now you mentioned AR, the acute respiratory disease. The last time that you came on. Sorry, the last time that you came on, that was a station break. the last time that you came on, you mentioned that is that particular disease, acute respiratory disease, is that phenomena or whatever the term is that something that has a different outcome than maybe in terms of treating it than maybe what we thought before?
Well, let me just answer in two parts. Back 17 years ago, you heard about SARS, SARDS. And SARS was severe respiratory distress syndrome, severe acute respiratory syndrome. And SARS is what we talked about, 13 years or 17 years ago in 2003. And it did not become a pandemic because it got shut down fast. Well, SARS and COVID-19 are in the same coronavirus family. So to answer your question, have we seen ARDS before? The answer is yes. Can you see ARDS in other kinds of diseases? The answer is yes. The first time in my clinical history of seeing ARDS was in a sickle cell disease patient. So what causes ARDS is not as important as the injury it gives to the lungs. In the case of the sickle cell disease patient, the sickling of the blood vessels cut off blood supply to the lungs. And this resulted in an acute respiratory distress radiographic picture. If you looked at the X-ray, it appeared that sand was filling up the bottom lobes of the lungs. It wasn't water. You could look at the X-ray and say, this doesn't look like pneumonia. It's different. And some seasoned attending at that time was able to identify it as ARDS, which can happen with sickle cell anemia disease. So other things can cause ARDS. It doesn't have to be COVID-19 that causes it.
Got it. So you're saying that some diseases bring along some of their other dastardly pals to help make things worse. The diseases they like
Absolutely.
to kind of.
It is a process, and what we're taught, and the whole reason we go to medical school, what they teach us is disease processes. And is how does this disease process behave? And we are trained to recognize, hopefully, as soon as possible when a certain fingerprint, if you recognize this disease process, you can say, okay, I know what this is. I've seen it before. This is how you treat it. So that's why we go to continuing medical education, is they keep giving us information about, here's the newest information about diabetes, and this is the disease process you should be looking for. Here's the newest information about high blood pressure, and here's the disease process you need to look for. So what this ER doc, in the midst of being on the front line, was still looking for disease process. And that's what I was complimenting him on, that despite however tired and frustrated or restless, he is still operating as a very competent physician.
Wow. Now, one other question, Brother, if I can. I've noticed that you see a lot of around the country, a lot of people are deciding that they're willing to brave whatever this is, whatever the name of this is now, like the COVID, and they're thinking that it's more important for them to go out, to get out and mingle and whatever, try to work, than to try to protect themselves. I mean, what would you say to those people? That's my final question.
Well, I have a very, I guess what some would say, a pessimistic prodromal outlook. My greatest fear, the fear that troubles me to the point that I get emotional, is in the Black community, where physical distancing is not even possible. If you have less than 1,200 square feet and you're 6 to 8 adults in that area of space, you can't stay 6 feet apart. And given that we are in the service industry. Many of us can't just work from home. We must go into the grocery store if you are a stock boy. You must go to the hospital if you're in environmental services. You must go to the bus and drive it, or if you're in the garbage disposal, to drive the trucks. Therefore, what my greatest fear is that COVID-19 is going to hit the low income families hard, June, July, and August. Why do I pick the hot months? People don't all have air conditioning. See, in Louisiana, this is my fear. Where you don't have air conditioning, your house is 90 degrees plus and it's 99% humidity, you cannot stay inside. And whatever kind of law is out there where you'll get arrested if you this or that or whatever, I know people who were in my patient list who went to the mall to cool off. They would say, "Doc, I don't have air conditioning, so I go and sit in the mall, and that allows me to get cool." And many of these were older women and older people with responsibility of children. My greatest fear is having reports of entire families found dead because one person had COVID-19 and brought it home. And the circumstances under which the people are forced to live, they cannot be 6 feet apart. They sleep within 10 to 12 inches of each other. They sit on the sofa, and we are the least protected. We're the least tested. And I just don't want to see apartheid type behavior to develop in these United States, where you got to have your papers and show someone that you're not COVID positive. I don't want people, like you heard your president identifying this as a Chinese disease. What happens when they start saying it's a Black disease, that the highest incident is a Black neighborhood? If they say, well, we're quarantining this Black neighborhood, where will we get our groceries? Everybody talks about food deserts. If you lock up some Black neighborhoods, they can't buy food. So I always remember in 1985, these United States dropped the bomb in Philadelphia, Pennsylvania. If you don't believe me, check it.
I remember.
So if they do that, I fear that we are regressing back to a position where Black Americans will be subjected to the same type of harsh injustices, not the covert kind that exist in our health care system, but overt injustices. I saw something recently this morning when I was looking internationally that in Chile, they're starting to discriminate against health workers, that they had signs up of a young man who was working as a nurse. They said, "Do not come home. We do not want you back in this building because you are exposed." And I'm saying, here's a healthcare worker saving lives that couldn't go home to his apartment because the apartment management and tenants feared that he would be bringing the infection back to their apartment complex. That kind of foolish behavior, that kind of fear, it is infectious, worse than the virus itself. And I'm shouting to my Black community and Black leaders saying, do not sit by and let this reoccur. We've suffered injustices enough. We need to be standing up and saying, I need to be tested. I want my immunity for COVID-19 identified. And those of us who have immunity, start donating your serum so that our very weak immune persons will have a chance to survive this.
Okay, that's pretty good, Dr. Bowles. Well, Leroy.
Yes, sir. And Doc, I'm going back into the hospital. When they open up, let's say in a person's death, and it's ARDS, what are they seeing in the lungs? If they do an autopsy, what are they seeing in the lungs of a pneumonia person?
Well, an autopsy is a definitive diagnostic. In other words, you can look at everything, you can slice and dice and get a good look. And my understanding is an autopsy of a person with COVID-19 is very much like ARDS, that the lung tissue liquefies. In other words, in the jargon of a clinical, we say necrosis. What that means in lay terms is every tissue has a firmness and it has a function. And as this tissue dies, the firmness becomes mushy. I would have you consider a ripened fruit. If you have a banana and it's just at its peak ripeness, it has a certain firmness. But if you leave it long enough, it gets soft and mushy. Well, the reports of autopsies is the lung tissue is in a mushy, a kind of slimy condition, meaning that tissue is dying. It's not just that there's not enough oxygen being pumped around the body. That's the job that the lungs do. But the lungs itself is being injured. And that is the key difference than pneumonia, where there's an accumulation of fluid, but the lungs should still be functionable. But the fluid is preventing it from doing its job. It appears in this condition, the lung tissue in itself loses its integrity, that the lung tissues can't do its job. So no amount of pressurized oxygen can make tissue that is dead do its job. And that's the key when we're doing autopsy, to verify if we're looking at pneumonia or ARDS. And indication now is the end stage. That is when a person is having respiratory distress, low oxygenation, they are going into an ARDS state.
Okay, so what are some of the approaches if you're on a you're in that hospital where that young man was speaking from?
I love to work with him. My first step, if we saw someone in the oxygen hunger state, and that's what he described, one of the things we always have in the emergency room as our armature is a steroid, and salumedrol is probably our first line for anyone with anaphylaxis, because the throat closes up on someone who's having an acute allergic reaction. It's our first line treatment for someone with severe asthma. It's a first line treatment with severe COPD. So bottom line is we use steroids in an effort to slow down the injury to the lungs. And we describe that as decreasing edema or decreasing lockdown of tissue. So I would suspect that somewhere in the repertoire of someone coming in with oxygen hunger, whether it's COVID-19 or anything else, someone is trying to reduce or reverse that acute situation with some form of a steroid. They probably are also using an ephedrine or some kind of venous dilation, or something that will open up blood flow more, increase blood flow. And we have a number of medications and drugs that do that. So with the idea that this is acute respiratory distress syndrome, when someone comes in with a severe air hunger, the treatment will not, I believe, be put them on a ventilator. That will not be the first line, but rather to use some kind of a pharmacological transition to let the person's body stop this necrosis process as best it can.
And okay, that's like putting up a dam real quick, and then there would be
to prevent it from continuing. And then that's why it's so important, folks, if you are tested antibodies to COVID-19, if you've had the infection, you got antibodies, please donate serum, because at that state, when someone's in air hunger and I'm doing steroids and I'm doing some kind of epinephrine or adrenal or some kind of vascular expanding process, the other thing is to give them a boost from somebody else. And that would be serum from a person who has antibodies. That would be a tactic to prevent the body from continuing to collapse, because that's like sending in soldiers that already recognize the enemy. You don't have to wait 8 to 10 days to learn who the enemy is. That's what the T cells would have to do in a healthy person when we get an infection. But if you're already sick and you're already tired, maybe you already got diabetes and whatever else, and I give you a boost of serum that has antibodies, I've just sent in the cavalry. I have introduced 100,000 fighters who know exactly what to do. I don't have to train them. I don't have to wait. So that's how important. That should be the visual, that someone cannot do their down on their knees and about to go face down, and you showed up and they stood back up.
Okay, now that opens up antibodies, and you know what has happened in the first person that creates antibodies, and what happens when you use it in the serum form with someone who's in that debilitated
Well,
state.
see, now this is where I shout out to my millenniums. I'm going to say, you want to be a hero? Go find out if you got antibodies. See, a healthy person, Mother Nature is brilliant. A healthy person who has a strong immune system, meaning they got enough vitamin D3, they got enough vitamin C, they got enough zinc in their body. They are weightlifters, they're long distance runners, they're in great shape. And here come COVID-19. And you get a little bit of cough, and you get some fever, you might be achy, but your bodies it's ready. The T cells say, come on, guys, and you knock out the virus, and 10 days later, you're back to where you were. What you have done is you've educated your T cells, probably some B cells in there, to recognize the virus. And this circulation is going to continue. It doesn't stop. So if you run into the virus again, if this is lifetime immunity, you don't sweat. The virus doesn't have a chance. Why? You got a ready army to recognize it. So if you healthy millenniums who may have had a sniffle think you might have beat COVID-19, you're strong, you're healthy, go test for antibodies. If you have antibodies, donate some blood, donate some serum, because that way you can really be a hero. You are saving someone's life who could not do what you did. If you're saying, well, I don't know what I want in life, I don't know which way to go, you can at least do that. And if nothing else, you can say, I saved lives today. So that's why, Brother Leroy, I keep shouting, I don't just want COVID-19 testing in the Black neighborhood. I want antibody testing also. I think every station set up to do COVID-19 in a Black community should be set up also to do, and there are two separate testing. The antibody testing is like a finger stick. It doesn't take more than 5 minutes. And if you're told, look, you've already, you got antibodies, you got not, then you need to turn around and say, okay, I want to donate a pint of blood to this cause. That is something we can mobilize. That's something we can do a shout out. That young folk, if you feel like you're Superman, if you feel like you Tarzan, that nothing can keep you down, then go be a hero for real. Go get your antibodies tested. And if you are with antibodies, donate some blood and serum. Then you really are the hero you think you are. You really are the invincible person you believe yourself to be. Don't just be a punk. Don't be a thug. Don't be a street kid. Oh, they told me to wear a mask. I ain't wearing no mask. Do something that's productive. You think you're that strong? Go find out. And if you are, do something good.
Now, are those people who show up with antibodies, are they designated as having been carriers, or they're beyond that?
Well, let me give an example. When I was doing medical school, I could not start my rotation in pediatrics unless I had had chickenpox, because you can't go onto a floor if you've not had the shot. So if you had not had chickenpox, they forced you or insisted that you get vaccinated. So I told them, I said, I never had chickenpox, but my older brother and sister did. And they said, okay, well, let me check your antibodies. And I'm thinking, well, why would I have antibodies? I never had chickenpox. As it turns out, I never had the little pimple of whatever the chickenpox itchy spots, but because I was so closely exposed to my brother and my sister, my immunities were very high. So I never needed the vaccine, and I never had a pox. Now my sister did, because my dad would scratch, and when you break a pox, you get what they call a pock mark. And I can remember my mom being angry at my dad because my sister would go to him and whimper and he'd help her out. So my answer to your question is, you can build immunity to something without having gone through the sickness as overtly as other people. So if you have a strong constitution and you believe you do, go have your antibodies checked. Maybe you are the superhero you always thought you were.
Brother Doug, do we have anyone in the chat room? Any questions? And while Doug is looking, in terms of the immune system, talk about, well, a person may be home, what do you call it, quarantine, self-quarantine. Talk about the value of elderberry, garlic.
And you know, that's my love. Well, first thing we need to address, and I may have done on other shows, but everybody didn't listen to everything. There are two types of immunity. Humans have two types. We have one that's based on your genetic makeup. Some of us are just stronger than others. You always knew that little skinny kid, grandmother would probably make him drink cod liver oil or pot liquor. He always thinner than everybody else, couldn't gain weight, always sickly, ear infections. We would say that his natural immunity is low, and that's a genetic thing. But then we have a second kind of immunity. And the secondary immunity is your body's ability to learn how to defend itself. The first point of secondary immunity, and I hope my young mothers are listening, is breastfeeding. When a mother breastfeeds the child, she is passing every immunity she has to the baby in her breast milk. So you are arming that little defenseless newborn with defenses by breastfeeding. So that's the number one boost to the secondary immune system, is if you are a breastfed baby. Number two, that if mother is not a clean fanatic and she allows you to sit on the floor, walk barefoot, pick up and eat off the floor, doesn't boil everything, you start to educate your T cells. There's an organ in the body called the thymus. And this is funny. Many people don't know that you only have the thymus from the day you're born until about 3 years old. And the thymus shrinks and shrinks and shrinks until it goes away completely. A 4 or 5 year old child would not have a thymus. What does the thymus do? The thymus creates a cell called T cells. Most of us know about T cells because when you had HIV, it killed off T cells. Well, T cell is like your Marines. I guess that's my best analogy. They go in first and they are ruthless. They will kill, they will attack, they will sacrifice themselves. So we have killer T cells and all kinds of T cells. Well, between the age of 6 months and 4 years old is when you educate your T cells to recognize what is not self. So during the time you're little, if you're the kid that went outside and picked up gravels and put it and stones and put it in your mouth, you might have picked up a bug and sucked on it. You had dirty fingers and put them in your mouth. Your T cell is actively learning, oh my goodness, this is bad, this is good, this is bad. So if you have a good army of T cells and you have them at the ready, when you get a viral infection, that's when the T cells take over. And that is what would be fighting our viruses now, would predominantly be T cells. So anything that you can do that can boost your immunity would be increasing the number of T cells response. You would be protecting yourself from any kind of outside invader. And there are foods that provide the right amount of, I'll say the right environment, the right enzyme activity, the right acidity, and that would include elderberry juice. Some people swear about cranberry juice because it protects the kidneys, and the kidney has a major role in the immunity. But the biggest immune gland in your body is your gut. I'm gonna repeat that. The biggest immune gland in your body is your gut. So if your gut is sick, what do I mean by a sick gut? You have a lot of gas. You have a lot of fat sticking out on your belly. We call it adipose tissue. You're constipated. You're going to bathroom once or twice a week. Those are all signs that your gut is not happy. And that means your immune system will be slow responders. So when you hear all this stuff about probiotics, they have the different kind of yogurts or probiotic drinks, but Mother Nature's probiotics are the following: sauerkraut. That will put in your bowel what you need so you're not sluggish, and that you do have a healthier immune system by way of the bowel. What else? If you're like Asian food, kimchi, which is very much like sauerkraut, spicy pickled beets, any kind of greens, you're getting your vitamin A's, which is a very supportive of good bowel health. And we've talked a little bit about increasing fiber, vitamin A and vitamin C. You get your collard greens, your mustard greens, and many low-income families, if you're in rural parts of America, you ate a whole lot more greens than you did meat. Many of us are chronically constipated or backed up, as they say, because we over-ingest meat. Meat is difficult to digest, and we want 6 pounds or biggie size this and biggie size that, and we clog up the system. So boost your immune system: elderberry juice, moringa teas, sauerkraut, greens of any kind, mustard greens, collard greens, as many salads. If you're not into the cooked greens, salads will help you because that is both fiber and ruggedness. So my thing is, Mother Nature knows how to mix nutrients better than any pharmacist. So when they say an apple a day, what they're telling you is eat the apple with the peeling on. Don't peel that apple. You need the roughage. If you're trying to look at what are my healthy things, you want blueberries. Why do you want blueberries? Because there's antioxidants. And I'm not a big proponent to going to the pharmacy for health kind of boosts. I try to work out what foods, and that's why I make the recommendation of oysters or Brazil nuts for the zinc, and just eat as many dark green leafy vegetables. Everybody now is talking about kale. Kale is okay, but it's not the best. Most Black families knew collard greens, mustard greens, mixed greens before they tried to identify kale. So that would be my suggestion for your secondary immune system. And you can thank your mommy for your first boost, which was breast milk.
And sleep and water.
So, well, if you're talking about what maintains your balance, and this is so important to my healthcare workers, I did a PowerPoint recently where I talked specifically to healthcare workers. What do you need to give your best, and you have to be at your best? And what makes you, only you know how much sleep you need. There are a lot of times that people try to brag, I don't need. When I was in medical school and doing ER work, I could do, I guess, what they call power naps and 3 hours to 4 hours and jump up and function. I don't even try to do that anymore. I don't see that as a badge of courage. Your body will tell you what you need, and my best advice is give it to it. If you are a person and you know you need 8 to 10 hours of sleep, don't be ashamed. Don't try to tell your friends. Don't try to hang. Tell them, do not disturb, and go get what your body needs. Your immune system, or one thing they tell you is your brain renews while you sleep. So if you're under a lot of stress and a lot of pressure, you can help yourself with sleep. Once I was talking to a young medical student I was working with, and he was talking, I don't think sleep's that important. I said, well, let me ask you one question. Why do you think when you come in the hospital, they put you in a bed? They don't sit you in a lounge. They don't put you out on a chase lounge and outside. They put you in some pajamas with your back end hanging out and put you in a bed. I don't care what you came for. So the whole paradigm or idea is that you need to sleep to renew yourself. You need to sleep to heal. So if you know that, you shouldn't have to be sick to renew yourself. And that's my recommendation. Whatever your body needs, do it. If you do a 12-hour shift in the hospital and you need 10 hours to sleep to recover, go home, put up a do not disturb sign and take your 10 out.
We conclude. Doug, do we have any chat room?
Uh,
Was there
yeah,
a
but
question?
no, there was only, we got a couple of people, they subscribe to the channel because they like what you're saying.
Oh, okay. Well, I appreciate that. I think it's so important that we communicate. And that's why I salute the young man that was in the ER. If we are silent, here's what I had written down, some notes that I was going to share when I talk to people is, when you are silent, when you don't tell someone your needs, you are teaching a person how to mistreat you. I'm gonna repeat that. When you do not tell people your needs, you're teaching them how to mistreat you. If you're tired and you need to sleep, you have a headache, and yet you say, well, I'll go ahead, I'm gonna make dinner, you are teaching the people you're about to make dinner for how to mistreat you. So we need to first identify with, how can I be my best self? I can't take care of someone else if I'm not taking care of myself. And the second thing that I'd like to share, that I'd love to have a young person or someone pick it up, when we're talking about the Black community, I saw something, it was a Native American chant someone was doing, I think when they were trying to run those gas pipelines through a reservation. One person stood up and said, if it is about me, don't do it without me. And I thought that makes sense. So Black American, if they're telling you that you're the #1 dying, and then they start talking about testing, you should say, hold up, I want to see some Black-faced person. I want to see some neighborhood person. I want a community-based person talking to me about this situation. Because if it is about me, don't do it without me. When I heard them in Louisiana saying 6 feet apart and everybody go home and stay home, I got excited and angry. And I started saying to my Black leaders, you need to be saying, hey, wait, Governor, I'm gonna have to open a community center in this area because the houses are small and the occupants are many. And if you are saying there must be 6 feet apart, then I gotta provide some space for them. Why would I lock up a community center when I know there's a house or 6 or 7 houses where people cannot maintain 6 feet apart? And I'm saying, community centers, why did you get elected? Don't you know your community? Why aren't you speaking up? One size does not fit all. If you were showing me a pair of shoes and said, these only come in size 5, and I will order you a pair, I am a fool if I say okay, because I don't wear size 5. If you're going to order shoes for me, let me tell you what my size is. You're not doing me a favor when you're making all the decisions and I'm having to compromise to meet what you've decided for me. So if it's about me, don't do it without me. And I think that is so important, and we need to empower our neighborhoods with that concept.
Dr. VELBA Boles of Louisiana by way of North Carolina on the wisdom table. We want to thank you very much for your time. Thank you for your research. Thank you for your great parents and grandparents, and the spirit that you have hopefully is contagious with many of our audience. And once again, the wisdom table extends their thanks to you. And until next time, my sister, God bless you.
With great pleasure. I look forward to it.
All right, bye now. And ladies and gentlemen, at 4 o'clock, we have an interview with Brother Dennis Speed of the LaRouche Group, and it's part 2 of a socio-political view on what is happening with the COVID-19 from an administrative standpoint. That's at 4 o'clock Eastern today. Thank you very much for plugging in to the Wisdom Table. Peace.